Welcome everyone. Today we'll be talking about resuscitation. So majority of the resuscitation will be completed in part 1. In part 2, we'll be mainly discussing about anaphylaxis, the allergies like urticaria, anaphylaxis, angioedema, then followed by recall questions based on resuscitation. So most of the resuscitation will be covered today. From exam point of view, it's very important. So we're expecting around at least minimum, we're telling around 20 to 25 questions. I want you to score high in this. We're trying to cover as much as possible in resuscitation, as deep as possible in resuscitation, because as an emergency physician, you are expected to know everything about resuscitation. So most, if not all, is taken from ALS and from resus.org. These are the official resources for resuscitation in UK, and most of the data is taken from here itself. We're not gone and taken the data from anywhere else. So it remains authenticated and it helps you to score or maximize your score in the examination. We're expecting you out of 25. I want all of you to score at least around 22 to 23. So I want you to get complete, if not all the marks from resuscitation questions. Many resuscitation questions do appear in the exam. So we'll start from the basics, then we'll go ahead into the cardiac arrest, then tachyarrhythmia, bradyarrhythmias will build up in that file. First, coming to and basic life support, BLS. The one algorithm given is in a community setting. We are more worried about in a hospital setting. In a hospital setting, first thing what you will be looking for is the patient unresponsive? If the patient is unresponsive, the next thing what you will be doing is you will be calling out for help. You need help. To resuscitate a patient, you need at least 5 persons. So you will call for help. So next step will be help. After calling for the help, this help might be putting out a resuscitation call or just shouting, can I have some help here? So it depends from institute to institute, from hospital to hospital, how you call for and help. The third step is you will looking for the signs of life. What do you mean by sign of life? We'll be looking for an central pulse. Ideally, a carotid pulse is felt maximum of 10 seconds. If you can't feel it, we will label them as this patient is in cardiac arrest. You'll also be looking for any respiratory efforts are there or not at all. So if there is no respiratory efforts, or if the central pulse is not felt at all, this patient is in cardiac arrest. We'll go ahead and start CPR. That is, first thing we'll be doing is chest compression. After chest, every 30 chest compression should be followed by 2 rescue breaths. Okay. So after 2 rescue breaths, this cycle keeps on continuing till you have an automated defibrillator in a community setting, or in a hospital setting, you have a manual defibrillator. Manual defibrillator is always preferred over an automatic defibrillator in a hospital setting. So this is basic life support. So what are the things you need to look out for? They will be testing you on how's the technique, what's the right technique to do in CPR, what's the right technique to give rescue breaths, or breaths, how do you give and rescue breath. So first thing is, how do you place your hands to give and CPR? So place your hand at the lower 1/3 of the sternum. Your dominant hand heel should be on the lower 1/3 of the sternum, and interlace your other hand as shown in this picture. Lock your elbows, and your shoulder should be right above your hands, so that with minimal efforts, you can compress it. You will be going at a depth of around 5 to 6 centimeters. You'll be going around rate of, that is, you'll be doing around 100 to 120 compressions over a minute. So that should be your rate. So for after every 30 compressions, you will be pausing, so that if there is one more help available, he'll be giving rescue breaths. If not, you will be giving rescue breaths on your own till the help arrives. Once the help arrives, if they have a supraglottic airway device, you can use the supraglottic airway device if you're trained enough to do so. Coming to the rescue breaths, before giving the breath, you want to open the airway. How do we open the airway? There are 2 techniques with which you can open the airway. This is the head tilt chin lift technique, what is shown here in the picture. The other technique is jaw thrust technique. Jaw thrust technique is the preferred one during trauma. If the patient is traumatic cardiac arrest, you will be doing a jaw thrust technique, mainly because You can't move the cervical spine. Cervical spine injury might be there. That's the reason you don't want to move the neck. You'll be doing just the jaw thrust and giving the rescue breaths. Each rescue breath is given over 1 second. While you're giving a rescue breath, make sure there is a chest rise. If there is a no chest rise, there is something wrong with your technique, or there is something obstructing the airway itself. Always make sure that if there is any interruption, that shouldn't be more than 5 seconds. For example, to place the chest lead shouldn't be more than 5 seconds. You need to do within 5 seconds. There shouldn't be any delay. Minimize the delay as much as possible. Once BLS continues into advanced life support, you should be knowing in and out. Questions appear from this. If not, couple of questions more than that will appear in the exam. The initial step is similar. Once you attach a defibrillator, for example, you're doing compressions, you've finished just 15 compressions, and one of your colleagues has attached the defibrillator or attached the monitor. You stop it. You don't wait till it finishes 30, or you don't wait for 2 minutes. You just don't wait. Once chest leads are attached, you just assess the rhythm. You stop the CPR and assess the rhythm. Always remember that to assess the rhythm, you need to stop the CPR. Otherwise, there will be artifacts on the monitor which might look like an shockable rhythm. That is, it might look like an VT, or it might look like an VF. So it will be difficult for you to assess. So you need to stop the CPR according to the guidelines. Once CPR is stopped, you will assess the rhythm. The rhythms are broadly classified, which is required for cardiac arrest scenarios, is whether the rhythm is shockable or whether the rhythm is non-shockable. There are only two rhythms which are shockable. That one is VF. VF comes like a bizarre line like this, not a straight line, a bizarre line like this. VT can be monomorphic like this, or it can be an polymorphic. So it can be an polymorphic, or it can be an monomorphic, as I have been drawing here. If the rhythm is shockable, if it is a VF like this, or it is a VT like this, then you will give the shock immediately. You can continue CPR till the defibrillator charges, then give and shock. It depends on how you have been trained, but you need to give the shock immediately. After the shock, you need to resume the CPR. Never check for the pulse. Once shock is delivered, resume the CPR for 2 minutes. So you will be doing for 2 minutes CPR in the ratio of 30:2. That is 30 compression to 2 rescue breaths for 2 minutes. Then only you will be checking for the pulse and the rhythm. In between, you shouldn't stop for anything. What if it's a non-shockable rhythm? Any rhythm other than VF and VT, we call it as a non-shockable rhythm. For example, it might be in pulseless electrical activity, where there is a normal electrical activity, but there is no pulse, there is no central pulse at all. Or it might be in complete flat line or asystole. Or there might be some other rhythm, like a junctional rhythm you're seeing on the monitor. So there is an organized rhythm, but there is no central pulse. Still, we call it as a pulseless electrical activity. Any electrical activity other than VF, VT, where there is no pulse, we call it as a pulseless electrical activity. Asystole is the one where there is a flat line. So if there is a non-shockable rhythm, you will immediately resume the CPR and ask your nurse, or you will be giving first dose of adrenaline. So the dosage of adrenaline is 1 mg. Okay, so you'll be giving first dose of adrenaline and continue the CPR for 2 minutes. Then you'll be going back to assess the rhythm. So this cycle will continue till you achieve the ROSC or the team decides to stop the CPR. Now question comes is when to repeat the adrenaline. You can repeat the adrenaline every 3 to 5 minutes or alternate cycles. So first cycle, that is every 2 minutes, we call it as an one cycle. So second cycle for 2 minutes will not be giving, no adrenaline. Third cycle after 2 minutes, you can give the adrenaline. Other way to remember is every 3 to 5 minutes, you'll be giving either 3 minutes, 4 minutes, 5 minutes, depending on your protocol. Guideline says every 3 to 5 minutes, you need to give adrenaline if it is a non-shockable rhythm. What about drugs in shockable rhythm? In shockable rhythm, initially we give shocks. So we don't give any drugs till 3 shocks. Okay. Give adrenaline only after the 3rd shock. You will not give any adrenaline before 3 shocks. Once 3rd shock is delivered, then you can repeat adrenaline continuously every 3 to 5 minutes. What about amiodarone? Amiodarone is given after 3rd shock and 5th shock only. After that, we will be not giving. After 3rd shock, we'll be giving 300 mg. After 5th shock, we'll be giving 150 mg. These are all IV boluses, usually given between 2 to 5 minutes. Over a time of 2 to 5 minutes, IV bolus what you're giving amiodarone here. It's not an infusion what you're giving. So this is the cardiac arrest algorithm which you need to remember. There are few more things what you need to remember. If at all you have an supra airway glottic device available immediately or during the resuscitation and you are trained enough to place it during ongoing CPR, then you can go ahead and place the CPR, place the supraglottic airway device. Once supraglottic airway device is placed, you need not stop the compressions. Compressions are done continuously for 200 compressions over 2 minutes. Usually it will be once 2 minutes are done, then you'll stop and assess the rhythm. What about rescue breaths? You will be giving around 10 rescue breaths over a minute when there is a supraglottic airway device. If supraglottic airway device, for example, you have used an LGA, okay, or you have used, there are many supraglottic airway devices are available. So use an iGel you are using, which is most commonly used in UK. It's a brand name or it's a device name slightly different from LGA. iGel is the most preferred one what you use in UK and it's manufactured in UK. That's why iGel is used most commonly. When you use an iGel, if you feel that there is leak of air is there because iGel is not sitting properly for any reason, then while giving the ventilation, we'll stop the CPR and give the ventilation in ratio of 30:2, where 30 stands for CPR and 2 stands for ventilation. Use waveform capnography if you are intubated. Here, supraglottic airway device, if you're not using supraglottic airway device, if you're directly intubating the patient, to confirm it, you use waveform capnography. Waveform capnography can also be used for monitoring the quality of the CPR. E2CO2, rapid rise in E2CO2 usually indicates ROSC, but that shouldn't be only indication for you to stop the CPR and assess. There should be some other signs to assess to stop the CPR in between before 2 minutes. What about mechanical chest compressions, which are becoming very famous nowadays? What they say or what they recommend is manual chest compressions are always better. If you don't have any resources or if you're doing a prolonged resuscitation, for example, in a toxic overdose, you want to do a prolonged resuscitation, or you've done a thrombolysis, you want to do an CPR for long duration of 2 hours, and you don't have enough persons or the persons who are there are getting exhausted, then they recommend to use mechanical chest compressions, or else mechanical chest compressions are not recommended. High quality manual chest compressions are better compared to the mechanical chest compression devices. So any doubts till here you can ask me before we go into the reversible causes.
Assalamu alaikum, Dr. Amin.
Walaikum salam.
When I rescue, when during arrested patient, when I put it endotracheal tube, how will ventilation ratio become? Yani how
endotracheal intubation, if you are skilled to place it, for example, anesthetic who's trained to intubate during ongoing CPR, CPR will not be stopped with ongoing CPR. If you have a trained personnel who can place an endotracheal tube, you can place it at any point of time during ongoing CPR. That shouldn't cause any delay or that shouldn't cause any pause in CPR. Once you place an endotracheal tube, you will be giving rescue breaths 10 per minute.
Doctor, you say in shockable rhythm, we start the shock first, but then we give the amiodarone and the adrenaline and amiodarone, صح? But CPR will start first, but then يعني the first CPR وبعدين الشوكابل أو يعني
See, till the defibrillator gets charged, you can continue the CPR. It depends on what kind of device you're using. For example, if you're using pads, which are placed here, pads, then you can continue doing the CPR till this pads gets charged. Once the defibrillator's charging is done, it usually prompts out saying the charging is done. Then you can stop the CPR and deliver the shock. For example, if you are using an manual, you are using an paddles to place the shock, which is usually done in developing countries. Paddles, while during CPR, sometimes you can place the paddles here and charge it and give. At that time, you need to stop the CPR while it is getting charged. So it depends on what technique you're using. Usually you do CPR till it is charged, because in UK, most of the NHS trusts have the pads, they use the pads.
Okay.
Coming to the amiodarone is only given after third shock and fifth shock.
Okay. Doctor, for the non-shockable, we start CPR first, but then we'll give the adrenaline. Well,
yes.
Adrenaline first.
You don't want to delay the CPR. CPR continues. For example, it's ongoing. I see there is an asystole. I'll tell, continue the CPR. Then I'll ask the nurse, can you please load 1 mg of adrenaline followed by 20 ml of flush. Once it's done, let me know. It's a closed loop communication what you're having. CPR starts first, followed by adrenaline.
Yani will not stop the CPR till the nursing giving the adrenaline?
No. CPR shouldn't be stopped. There shouldn't be any delay in CPR. It should be less than 5 seconds, any delays, if at all, if they are. So your assessment of the rhythm should be in 5 seconds, within 5 seconds.
Sir, for rescue breath, sir.
Excuse me, for non-shockable rhythm, just give adrenaline. But amiodarone just in shockable rhythm, right?
Yes. Yes.
Okay.
Amiodarone only after third and fifth shock. In shockable rhythm, you give adrenaline also after third shock, and you give after every 3 to 5 minutes after that. Here, you immediately give the adrenaline, and every 3 to 5 minutes, you repeat the dose.
Sir, in shockable rhythm, after the third shock, are we supposed to give both adrenaline and amiodarone?
Yes, both.
Okay, together.
Together.
So
one
because
after
in
another.
AHA,
it's not in the same syringe you are loading
alternate.
it.
Yeah. Okay.
In two different syringes, you are loading it and giving it back to back.
Yes. Okay.
This is given undiluted, sir.
Sorry, can you repeat?
What about the intubation?
Is adrenaline given undiluted?
We will talk about the drugs, how to give it.
Okay. Well, what's the specification that said pulseless ventricular tachycardia and pulseless ventricular fibrillation? Sir, the way is mentioned pulseless ventricular fibrillation. Sir, for tachycardia, it's not mentioned like that, sir.
VT can be with pulse. VF, as I was explaining in ECG chapter, it is vibrating, it's just fibrillating. So whenever there is an VF, we are sure that the patient is already in cardiac arrest. That's why they don't mention it as pulseless. VT can be with pulse. So the patient having a tachycardia can be because tachycardia and having a central pulse can be ventricular tachycardia.
Okay. You mean, sir, that
one of you at a time.
You mean that for shockable reasons that the patient could just have ventricular fibrillation or pulseless ventricular tachycardia?
Shockable rhythms are two.
لا أمير ماشي أمير أساس كلمه كله من أنا ماشي.
Coming to your question, shockable rhythms are only two rhythms. One is fibrillation, that is ventricular fibrillation. Other one is pulseless ventricular tachycardia. There shouldn't be pulse here. In both cases, in VF, we are sure that there will not be pulse. That's why we don't mention it as pulseless ventricular fibrillation. VT, we are not sure there can be pulse. That's why we call it as in pulseless ventricular tachycardia. These are only two rhythms where you can shock the patient. Rest all other rhythms comes in this category. Usually it will be either pulseless electrical activity or it will be an asystole where we'll continue the CPR and give adrenaline.
Dr. Amin, when you do intubation?
Intubation can be done any point of time if you have a skilled doctor who can do the intubation during ongoing CPR. CPR can't be stopped. If you're not skilled enough to do with an ongoing CPR, then you don't intubate the patient. Intubation shouldn't take the priority over the CPR. CPR gets the priority over intubation.
Sir, if for rescue breath, sir, if there is a risk of disease spread or disease, what should we do then?
For example, in COVID cases, you are giving an back mask ventilation where there is risk of aerosol spread of the disease. The patient might be having a COVID. Then you need to wear and protective equipments. That's why initially, if you ask you what they say is first thing what you need to use is personal protective equipment should be worn, which includes your wearing a mask at least at the level of N95. If not, you're not wearing a respirator. Usually in UK, they'll be wearing a respirator, which will avoid any respiratory diseases to be spread with an aerosol. So while intubating also, you're exposed. While placing on NIV also, you're exposed. Usually N95 masks are higher grade. Usually a respirator will be used. So we are going to the reversible causes there. One thing you need to remember is if the patient is in cardiac arrest, unless you correct one of the reversible causes, the patient will continue to be in a cardiac arrest. So what is the insult which is causing the cardiac arrest? What is the cause which is causing the cardiac arrest? Broadly, they are classified into 4 H's and 4 T's, which we'll be going through now. These 4 H's and 4 T's, you need to treat them. If you treat them, you get the ROSC. If you don't treat them, you don't get the ROSC. So it becomes important. They test you in OSCE also. They test you extensively in SBA exam also, because you need to be aware of these 4 H's and 4 T's. 4 H's are hypoxia, hypovolemia, electrolyte imbalance, hypothermia. 4 T's are cardiac tamponade, toxins, thrombus, either in coronary artery or pulmonary arteries, tension, pneumothorax. So each one of this will be seeing now. So coming to hypoxia. Hypoxia, you are giving rescue breaths. So kind of you are managing. If you have a skilled labor, then you can go for endotracheal intubation or supraglottic airway device. If you're skilled enough, you can place it. So hypoxia is kind of dealt involuntarily while you're doing a resuscitation. Hypovolemia, you need to suspect an hypovolemia depending on the history or what you're seeing on the patient itself. For example, a traumatic patient is profusely bleeding. It can be from any part, or there is an obvious deformity seen in the thigh suggestive of a femur fracture and acute bleeding. That is causing the hypovolemia. Only bleeding doesn't cause the hypovolemia. There might be other cause also causing hemorrhagic bleed, like upper GI bleed. So bleeding only doesn't cause hypovolemia. There might be a fluid loss. For example, there might be third spacing of the fluid, as you see in pancreatitis, as you see in sepsis, as you see in burn patient. So there is third spacing of the fluid. So there is a fluid loss from your vessels. So intravascular volume reduces here. What you do here, for emergency purpose, we start with IV fluids and activate major hemorrhage protocol and try to give blood where there is blood loss. If there is no blood loss, we usually resuscitate, for example, a patient with sepsis or patient with burns who is in cardiac arrest, we resuscitate them with only normal saline. Crystalline fluids in general, they say Hartmann's is the preferred one. There are contraindications for Hartmann's. That one will study in sepsis which fluids to be coming across. Whenever there is an electrolyte imbalance, especially we are looking for kalemic, hyperkalemia, that is potassium, high potassium levels we are looking for. And we are looking for the magnesiums. These are the 2 things which we are really bothered about. If there is hypo, what we do is the patient is having low potassium levels and in cardiac arrest, then you can use 20 millimoles over 10 minutes, followed by 10 millimoles over every 5 to 10 minutes till the potassium levels come back to the normal range. If there is low potassium levels, especially less than 0.65 millimoles per liter, that's when you will be giving 2 grams over 1 to 3 minutes. Basically, you're pushing the magnesium 2 grams in the IV line, what you are having. The last H is hypothermia. Hypothermia is low body temperatures. Usually if it goes beyond or less than 24 degrees Celsius, that's when they go into cardiac arrest. We'll be discussing again about it. What we'll be doing here is we'll be actively warming and giving warm fluids. Actively warming in the sense we'll be removing all the wet clothes if they are, all the clothing what he is having. Then he'll be wrapped with a blanket which will warm. Okay, at the same time, you'll increase the room temperature. You will give the IV fluids which are warm. So you are actively rewarming as much as possible in these cases, along with passive rewarming also. How do we correct an hyperkalemia in an cardiac arrest scenario? Okay, we'll be discussing again hyperkalemia in nephrology in detail. Here, we are just talking about in an cardiac arrest scenario, what we do. We give calcium. Calcium is the most important drug in hyperkalemia because it stabilizes the heart. The ECG changes will come down. That's when he'll return back to the ROS. That's when the patient will come back from cardiac arrest. So calcium therapy, what you'll be giving? Calcium chloride or calcium gluconate. One is not superior over another one. But one thing you need to remember is calcium chloride has more calcium compared to that of calcium gluconate, almost 3 times more. That's why the dose is also 30 ml when you are giving calcium gluconate. It's 10 ml when you are giving calcium chloride. By chance, it shouldn't come appear in the exam. If at all, if they mention both calcium chloride and calcium gluconate in the exam, choose calcium chloride because it's 10 ml. You can push it easily in. Next thing is you'll start the infusion. A short-acting infusion, the most common used one is human atrapid. Human atrapid 10 units mixed in 50 ml of 50% dextrose, you'll be giving over 15 minutes you'll be giving. Then followed by that, you'll be giving soda bicarb. In a cardiac arrest, or if there is a pH low, you always give soda bicarb 50 ml. This is 8.4% solution you're giving. 50 ml you'll be giving of 8.4%. It will come up to 50 millimoles you'll be giving bolus. If you got in ROS, still there is a persistent hyperkalemia, only minute changes are there, you might be thinking about dialysis, but ongoing CPR, patient who is in cardiac arrest, dialysis can't be done. Salbutamol nebulization is practically not possible during a cardiac arrest scenario because the patient is not breathing at all. If you're ventilating the patient, for example, you have placed an ET tube and connected to a ventilator, or you're backmasking these patients, there might be a vague possibility of giving an salbutamol nebulization. Most of the time, this will not be possible, and this will not be the right answer to choose it. So always remember, the first thing what you need to give is calcium therapy. Calcium chloride is the preferred one because it's more concentrated calcium. What is present in 10 ml should be sufficient. What about 4 T's we are talking about here? First one is the cardiac tamponade. So in a cardiac arrest scenario, if you see an black color thing surrounding the heart, what is here, then you consider it as an cardiac tamponade. So here, what you are seeing here is, you can clearly see that this is a live image what you have put up here. This is the fluid around the heart. So this patient is in cardiac tamponade. Cardiac tamponade in a cardiac arrest, we will be doing clamshell thoracotomy, nothing but thoracotomy as shown in this picture. So you basically put a big incision and open the chest completely, then treat the cardiac tamponade. Toxins, depending on which toxin or he might have taken, you need to give the drug accordingly. For example, beta blocker overdose, you might give an glucagon, or for example, an opioid overdose, you might give an naloxone. So depending on an paracetamol overdose, you might give an N-acetylcysteine. So depending on the toxin, you will be giving reversible agent, which we'll be talking more about in toxicology chapter. Thrombus. This becomes difficult to diagnose if you don't have anyone to give the history. If you have a typical history of an chest pain, profuse sweating, he complains of chest heaviness, hereditary on left arm, then you can think about, yes, it might be an MI which is causing this. PE, if there was any DVT, signs and symptoms, or during CPR, you're seeing that one limb is grossly swollen and engorged veins are there, well score goes very high. If you see his limb, then you can think of an PE. The best way to find out PE during an ongoing CPR or when the patient is unstable, Thus, when you will be doing an echo. What do you look out for echo? In PE, we will look out for an RA-RV dilatation. If there is an RA-RV dilatation on an echo, or that is extended fast scan, then we directly go ahead and thrombolize. There are various drugs which are used. You need not remember the dosing. Most commonly used for MIs are tenecteplase. Most common used thrombolytic agent is altiplase in PE patient. That is pulmonary emboli. We use altiplase. Most commonly MI, tenecteplase. Doses you need not remember. Don't worry about the doses. Once you thrombolize the patient, so you're suspecting a PE, there is RA dilatation. I know it is an PE. I want to thrombolize this patient. You're given altiplase. Continue CPR for minimum of 1 hour, if not 2 hours, because it takes time for this drug to act and to revascularize the artery where it has blocked. So you need to continue for 1 to 2 hours CPR. So you need to prepare yourself. Make sure you have enough personals. Make sure you have enough man strength. Make sure you have enough resources before you decide to give an thrombolytic agent. There is no point in doing an CPR for 20 minutes and stopping and giving an thrombolytic agent. What about tension pneumothorax? Tension pneumothorax is nowadays diagnosed only on ultrasound. No x-rays are done. Ultrasound is more sensitive than an x-ray to diagnose an tension pneumothorax. You just placed a curvilinear probe on the chest in 2 different positions and get an barcode sign. What you're seeing here is an barcode sign. There might be other signs like reduced air entry, tracheal deviation to the opposite side, but this reduced air entry will be very difficult to auscultate when there is ongoing CPR. Tracheal deviation is a late sign, so preferred sign is a barcode sign. Once you see an barcode sign in ultrasound, or once you are sure that it is a tension pneumothorax because there is a tracheal deviation or any one of this following is present, then you directly go ahead and do needle decompression. Needle decompression, where you do it is important. You do it in 5th intercostal space, just anterior to the mid-axillary line, as shown in this picture. In anatomical safe triangle is the latest guideline for needle decompression in adults. In children, it's mid-clavicular line in 2nd intercostal space on the affected side. This completes our 4Hs and 4Ts. Now we'll be going into special situations like obstetric asthma and hypothermia. What changes needs to be done for our ALS algorithm, what we have learned so far. So one thing I need to tell at the end here is, I didn't tell at the starting, is what is the adrenaline dose we give during cardiac arrest. Adrenaline dose, what we give is 1 mg. The dilution here is 1:10,000. So it comes around 10 mils. So we are giving a push of 10 mils. Never give 1:1000 concentration. This is not the recommendation. These are not the guidelines. Okay, 1:10,000 is the guidelines what we are supposed to give. That comes to 1 mg. In mls, it's 10 ml if the dilution is 1:10,000. Usually in the ampules, what you get is 1:1000 dilution. You need to dilute it with a normal saline so that it becomes 1:10,000 dilution. Okay, so you make that 1 ml into 10 ml by adding 9 ml of normal saline. That will be 1:10,000 dilution. So that completes our reversible causes of 4Hs and 4Ts. Anyone has any doubts can ask me now.
Dr. Amin, when you stop a CPR, there is a maximum time for.
We'll talk about it. About the CPR, when to stop, we'll talk about it. We'll not reach till there. We'll talk about the CPR, when to stop about it.
Excuse me, Dr. About sodium bicarbonate, just given for hyperkalemia or the acidosis that happen from hyperkalemia?
We are giving, as any patient who has an hyperkalemia and cardiac arrest, we give it to them.
Okay.
So the whole 10 ml is given in this for adrenaline, sir?
Yes, 10 ml dilution of 1:10,000. That comes to 1 mg.
So the whole 10 ml is given for the adrenaline as for the rescue, right, sir?
Yes, it's a single dose is 10 ml. You will be repeating every 3 to 5 minutes.
Sorry, doctor, the management about pulmonary embolism, because sometimes we are use low molecular weight heparin. And you said for tissue plasminogen activator, which one?
How it will be
Give
helpful
heparin?
for you to use an low molecular heparin in an PE in a cardiac arrest scenario? It's a cardiac arrest scenario. Usually low molecular weight heparin will help you to not to progress it. It has progressed enough to cause an cardiac arrest. So you need to break down the thrombus, what is there. Okay, so low molecular heparin doesn't play a role in a cardiac arrest scenario.
So the patient is in cardiac arrest. Will it be difficult to dilute for 10 ml instead of that to give it as 1 ml? So what is the difference between giving in 10 ml or giving it as directly to 1 in 1000? So
it's basically, it doesn't reach because the cardiac arrest is there. There is no ongoing circulation is there. If you give in 10 ml up, you can push it and it will reach to the heart. So circulation is important. That's why they recommend giving 1:10,000 dilution, not 1:1000. Usually the recommendation is after you give an 10 ml, that is 1:10,000 dilution, you need to give 20 ml of bolus of normal saline also, so that it at least reaches. You need to push it really fast so that it reaches into the circulation, because you're giving in a peripheral vein. It has to go to the systemic circulation to be really effective. That's the reason we give 1:10,000 dilution, not 1,000 dilution. And the recommendation are in your crash guard, there should be syringes already preloaded with 1:10,000. It shouldn't be during cardiac arrest you're diluting. It should have been diluted in every shift when you start. We're going into the special circumstances now. First, we'll be looking at the obstetric. So hand positions remains the same, no changes in hand position. If at all the patient had an eclampsia, that is, she is pregnant more than 20 weeks of gestation, plus had a seizure before cardiac arrest, you give an magnesium of 4 grams IV over 5 to 10 minutes. What about if the lady is more than 20 weeks of gestation, or the uterus is palpable above the level of umbilicus? We usually deliver it within 5 minutes of cardiac arrest. You need to remember within 5 minutes of cardiac arrest, the recommendation are to deliver it in the ED itself. So they are expecting as an emergency physician you to deliver it, because obstetrician might not be available. Or if you have already gotten call, make sure the obstetrician is there in the resuscitation room to deliver it with all the equipments ready. What about placing the defibrillator plates? Is the same position. We don't change it. Place it as much as possible in the same position, because the breast might be engorged. You might not be exactly able to place in the same position, that is just below the just below the clavicle on the right side. On the left side, you will be placing placing around the 5th intercostal space over the anterior axillary line. So as much as possible, we'll be placing close to this anatomical landmarks itself. Again, no changes there. Most of the time, the cardiac arrest might be because of hypoxia. That's why they recommend early tracheal intubation if possible. Fast scan, if you're doing, you can just keep the probe to monitor the fetal heart rate also. The other important thing here is the left lateral tilt. 2 things you need to remember from this slide, which is very important, is you need to deliver within 5 minutes. So this is the one important point. Next is the left lateral tilt. Why do we do a left lateral tilt? The main reason for left lateral tilt is on the right side of the vertebrae, in the midline on the right side of the vertebrae, there in the retroperitoneal region, there is an inferior vena cava. If the gestational age is more than 20 weeks, the fetal weight will be around 1.5 kgs. That is sufficient enough to cause compression of inferior vena cava. So there will be no venous return and your resuscitation will be hampered. So what you'll be doing is you'll be placing a wedge on the right side so that the mum gets tilted towards the left side. So you're in the left lateral position. The other method to decompress the left vena cava, inferior vena cava, is just manually pushing the fetus to the right side as shown in this image. So it is here, you are just pushing towards the right side. The compression here will get reduced. We're not worried about aorta because usually arteries are non-compressible, and with the weight of that much, it might not compress. So we're not worried about aorta. We are just worried about inferior vena cava. These are the two important changes what we are looking for in the obstetrics. What are the specific causes you can see in an obstetric cardiac arrest? It might be an hypoxia because of an pulmonary emboli or amniotic fluid emboli, or it might be because of pulmonary edema. This scenario we are already spoken about in cardiology chapter. Thrombus are also the same reasons. Because of thrombus, there will be hypoxia. Because of that hypoxia, there will be a cardiac arrest. So it's a cycle what is going on. There might be an hypovolemia we can expect, especially in third trimester because of abruptio placenta or placenta previa, or during delivery and a uterine rupture or a traumatic uterine rupture can happen. Cardiac tamponade, especially seen in peripartum cardiomyopathies. Toxins can happen. For example, they are done an episiotomy and the local anesthesia is given more than what was supposed to be given, ended up in toxic effect of local anesthesia and cardiac arrest. Or magnesium is given because of an eclampsia and they are overdosed, and that might have caused an cardiac arrest. So these are the specific causes, obstetric causes for a cardiac arrest. Now we are getting into an hypothermia. Hypothermia is classified into 4 stages. This is known as switch stage of classification. Usually when the core body temperature comes or becomes below 24 degrees Celsius, that's when we suspect an cardiac arrest. Okay. During cardiac arrest, the ALS algorithm is changed. These changes are tested in every diet. So at least one question for sure will come from this table what we have put up here. Okay, this table is very important. So we'll go through this table. This is for adrenaline. This is for shock. So first 3 shocks you will give at any temperature. So temperature doesn't matter at all. Whatever the temperature might be, you can give first 3 shocks. For the 4th shock, you need to make sure the core body temperature is more than 30 degrees Celsius. This is for the shock. Now we are coming to the adrenaline. Don't give any adrenaline at all if the core body temperature is less than 30 degrees Celsius. Between 30 to 34 degrees Celsius, give adrenaline every 6 to 10 minutes. This is the double the duration. If you remember in previous slides in cardiac arrest, we said 3 to 5 minutes. We are doubling the duration here between 30 to 34, between 30 to 34 degrees Celsius. Once it goes more than 34 degrees Celsius, for example, it is 34.1 degrees Celsius, that's when you can start giving adrenaline at a regular interval, what we discussed initially. These changes are very, very important. Definitely one question comes. I don't want anyone to lose any marks in this question. It should be a scoring for you. Most of them lose their question, they get confused. That's why we have made a tabular form this time around, and we have put up here so that it will be easy. Keep this tabular form to revise it before you go the exam, because I don't want anyone to lose a mark here. Most of them fail with 1 or 2 marks. You shouldn't be one who is losing marks here and failing the exam. I want you to pass by scoring here. Coming to asthma. Asthma is an interesting disease where there are various causes, and there is an interesting thing known as dynamic hyperinflation which occurs. What do we call as an asthma? Asthma as an obstructive airway disease. In literal sense, obstructive airway disease means it allows the air to come in. So everything is coming in, but it doesn't allow to go out. So nothing goes out. It gets accumulated in the lungs itself. That is known as dynamic hyperinflation. Usually during cardiac arrest with the rescue breaths, what we are giving, and with the CPR, what we are doing, dynamic hyperinflation of the lungs is rare, but it can happen. Dynamic hyperinflation can happen, especially if the patient is already intubated and you are seeing the patient in cardiac arrest. The chances of hyperdynamic inflation is very high. How do we treat an hyperdynamic hyperinflation here? If you are put up an advanced airway, disconnect the advanced airway. For example, if you put an ET tube, disconnect it to the ET tube is connected to a back mask ventilation, disconnect the back mask and compress the chest from both sides. Apply pressure over the chest and compress it So all the air which is accumulated in the lungs comes out with the pressure what you are applying, then reconnect to the bag mask ventilation, continue the CPR and start doing your bag mask ventilation. That is what is recommended for hyperdynamic inflation. That is nothing but gas trapping. This gas trapping might cause increased transthoracic impedance. That is nothing but increased resistance to the flow of the electric, increased resistance to flow of the current. So while giving shock, they recommend that giving an higher shock energies, you might have to use it if the initial defibrillator attempts have failed. Basically, they are saying higher shock energies are required if the patient is in hyperdynamic hyperinflation, because there is an increased resistance to the flow of the current. Tension pneumothorax is also possible. That is one of the important causes for cardiac arrest in asthma. Whenever they are in cardiac arrest, usually suspect in bilateral. Unilateral tension pneumothorax might not cause an cardiac arrest in asthma. It's a bilateral tension pneumothorax which causes an cardiac arrest. Do a needle compression as followed by ICT. Sometimes during needle decompression might not be easy while ongoing CPR. The needle might come out or needle might get wrongly placed. That's when they recommend doing bilateral finger thoracotomy. We'll be talking about this in coming up slides a little bit more. Coming to hypoxia, it is an respiratory disease. Hypoxia can happen. Hypoxia itself can trigger cardiac arrhythmia. So these are the various causes for cardiac arrest. These are various changes what you expect during a cardiac arrest. Last thing what you need to remember is there will be an increased airway resistance. So early intubation, if you haven't trained personnel, you can attempt an early intubation. These are the special circumstances. One of the other special circumstances is a trauma. This is taken from an ATLS 10th edition. How to resuscitate a patient who comes in cardiac arrest due to trauma. So initially we started as a regular CPR. We started assess the rhythm as we do in any other medical causes. After 2 minutes, if you are not able to achieve the ROSC, you will go ahead with bilateral chest decompression. So what you will be doing is just anterior to the mid-axillary line on both sides of the chest in 5th intercostal space. You will put an incision till the level till you pierce the parietal pleura. So you're opening the parietal pleura bilaterally. If there is a tension pneumothorax because of the trauma, you will be able to achieve the ROSC immediately. This is known as finger thoracotomy. What we mentioned is as a bilateral finger thoracotomy, or bilateral chest decompression means the same here in trauma cases. So you are able to achieve the ROSC, then you'll be putting the chest tubes because it was a tension pneumothorax, you are able to achieve it. If it is a massive hemothorax also, this will be helpful. If you are not achieved the ROSC, so within 1 minute of this, you need to achieve the ROSC. If you're not achieved the ROSC, you will open the chest. That is nothing but thoracotomy is done. You open the chest and have a look. What you'll be having a look, you're looking at cardiac, you're looking at the heart, where the heart is the cause. For example, there is a cardiac tamponade which has caused it. If cardiac tamponade, then you can treat it accordingly and you will, or you must be able to achieve the ROSC. If it is because there is no cardiac injury, there is a profuse bleeding, you will first look whether the bleeding is in the chest. If it is in the chest, then the culprit artery will be clamped. Okay. If it is in the abdomen, what you'll be doing is you'll be just clamp. If thorax, there is no artery which is bleeding, then it has to be in the abdomen. If it is in the abdomen, what you'll be doing is, if this is the diaphragm, if this is the aorta which is going through, you will clamp it just below the diaphragm or just above the diaphragm, you'll clamp it. So the bleeding, what is happening in the abdomen will stop and you'll be able to achieve the ROSC and shift this patient immediately to cath lab for a rescue surgery. Along with this, you always need to have 2 large bore cannulas and resuscitate with fluids and bloods as recommended previously. So this is what is recommended by ATLS in the 10th edition, what to be done in a traumatic cardiac arrest. So what are the reversible causes we are thinking? Hypoxia, as I told you earlier, we usually intervene shouldn't be a problem. Hypovolemia. How to treat an hypovolemia, especially an hemorrhagic one. So compressible hemorrhage. So you're seeing there is an active bleed. For example, there is a stab injury in the abdomen and you're seeing an active bleed which is happening. Just apply pressure there and try to stop the active bleed. If that fails, then do an pressure dressing and see whether that stops. If that fails, use an tourniquet. New thing says even tourniquet fails, you can use hemostatic agents also, but it is still under research. Usually tourniquet should be tight enough so that the artery itself is compressed and the bleeding will stop. What about non-compressible hemorrhages here? For example, femur fracture, there can be enough blood loss to cause an cardiac arrest. You just splint it, place back into a normal anatomical position, the bleeding will stop considerably and you can treat or you can get a ROSC pack. Along with it, you will start with IV fluids and bloods if available in a non-compressible fractures. In compressible fractures also, you will be starting IV fluids and bloods. Along with it, the priority here is given over IV fluids and blood is to stop the bleeding. If you don't stop the bleeding, no matter how much blood you pour in, it will be coming out through this side where it is bleeding from. So you will not achieve the ROSC. Same thing here, non-compressible. Most of the time, unless it's a fracture, most of the time you'll not be able to do anything. That's why we end up giving IV fluids and bloods. And usually we assume that this IV fluids and bloods might cause tamponade effect and stop the bleeding. Remember that during an cardiac arrest, when there is an active bleed, what is suspected, keep the systolic blood pressure around 90. We don't want the blood pressure to go really high. If the blood pressure goes really high, the clot what is formed will get dislodged. The clot formation will be difficult. It might get dislodged. So we will be maintaining systolic pressure around 90 to 100. That should be sufficient. That should be the target. Tension pneumothorax, we have already discussed what to do with. Cardiac tamponade, thoracotomy needs to be done. So what are the special consideration for a prolonged CPR? We call it as a prolonged CPR if you're continuing CPR for more than 40 minutes. Hypothermia patient, unless you warm them, you can't definitely say this patient will not be revived. So not dead until warm. That's what we call it. So hypothermia, prolonged resuscitation usually is recommended. Asthma, correct dynamic hyperinflation first. If that causes delay, like 40 minutes, you require to correct the dynamic hyperinflation, prolong it as much as possible, but correct it before calling the patient dead. Toxins. For example, opioid toxins, there are documented cases that CPR going for more than 4 hours, they have gotten ROSC in toxicology. So toxins, you can expect to continue CPR for more than 40 minutes. When you're using thrombolytic agent, as I told you, should be continued at least for 1 hour, if not for 2 hours. Pregnancy, don't call it dead before you do C-section, remove the fetus. Continue in young patients. For example, there are no comorbidities and the patient is persistently VF or pulseless VT. Continue the CPR till this patient becomes PEA or asystole or you're exhausted your resources. When to stop the CPR? So these are the things where you continue for longer duration. You're doing for a longer duration or everyone is exhausted, everything is done. When to stop the CPR? You stop the CPR keeping multiple things under consideration. For example, duration of CPR. Usually we do it for 20 minutes. If the duration is more than 20 minutes, you can think about stopping of CPR. No response to the interventions. What do I mean? You corrected all 4 H's and 4 T's, still there is no response at all. Persistent low EtCO2, what you are getting on the monitor. On ultrasound, that is a EFAST, what you're doing, cardiac standstill. No cardiac activity is seen at all on ultrasound. Usually combination of this is what will prompt you to stop the CPR. For example, you have corrected all the H's and R's, that is, and the CPR was more than 20 minutes, you can think of stopping the CPR. Or there is a cardiac standstills and you have corrected all the reversible causes, still ROSC is not acute, you can think of stopping the CPR. So more than one is usually used to stop the CPR. For example, in the exam, if they're given all the 4 options and asked you to choose one, choose cardiac standstill on ultrasound. It is very sensitive. 99% of the time, you will not be able to achieve ROSC if there is a cardiac standstill on ultrasound. So this is the most sensitive one compared to all these four. It is not always that you will be able to achieve the ROSC. Sometimes you will not be able to achieve the ROSC and you will stop the CPR because of the indications here. And how do you confirm the death? Okay, you need to declare that you're just stopping the CPR. How to confirm there is a death or patient is no more? How to tell the patient is no more? What you do is, for minimum of 5 minutes, you'll be checking for central pulse, heart sounds on auscultation. This is heart sound on auscultation. Respiratory sounds on auscultation. Any signs of life in this 5 minutes, you'll be checking, for example, movements. He started moving his hands, or he started blinking, or there is any respiratory effects. You look for 5 minutes for all this. For 5 minutes, if all of this are absent, then you can declare death. Okay, this is not a must to declare an death, but if if required, you can check. Depends from institute to institute, but these things are the most important thing. You need to say this in your documentation. For minimum of 5 minutes, I've checked for 1, 2, 3, 4 things I've checked, and there were no signs of life, and declared time needs to be documented in your notes. If you have enough time, you can check for the pupillary reflex by flashing the lights and looking for pupil constriction. Usually they will be dilated and fixed. Corneal reflex by touching the sclera by on cotton or in paper, you can see whether there is a blinking absent or not. Any motor response when you press just above the eye, there is supraorbital pressure when you do it. There are no motor response at all. Also can be documented. It is not very important. This is the very important what you need to document. Anyone has any questions here before we go into post cardiac arrest algorithm can ask me now.
Sir, in case of hypothermia, hello.
Yes.
Yeah, in case of hypothermia, it should be delayed, right? I mean, 6 to 10 minutes is the time period what we are administering adrenaline.
It depends on the core body temperature.
So what about the dose, sir? Is it the same dose what we are administering?
Same dose. There is no changes in the dose. The duration is changed. So between 30 to 34 degrees Celsius, you're giving double the duration. Less than 30 degrees Celsius, you're not giving at all. More than 34 degrees Celsius, the duration remains the same. In all these scenarios, the dose is same. The dose is not changing.
Okay. And the dynamic hyperinflation case of asthma, can you just explain me once again?
Dynamic hyperinflation, what happens in asthma? Asthma in general, we all know that it's an obstructive airway disease. Obstructive airway disease is nothing but it allows the air to come in. It allows the air to come in. It doesn't allow the air to go out. So the air coming in and in, if you start rapidly, you have in some junior who is bag masking and he masks rapidly, he's bag masking this patient. What will happen? More and more air get accumulated. Nothing is going out. This lungs become expanded and there is no place for the incoming air at all. This is known as hyperdynamic inflation. What we need to do is we need to apply pressure from outside so that this air comes out. So disconnect the bag mask, what you have here connected to your ET tube. Apply pressure, that is you're manually compressing his chest as hard as possible so that this air, everything gets, it will be a gush of sounds which will be coming out through the ET tube. Then you can connect back to the bag mask ventilation and continue the CPR. That's how the pathophysiology and treatment of hyperdynamic inflation in asthma.
Assalamu alaikum, Dr. Amin.
Walaikum salam.
In case of hypothermia, you said the temperature is 30 to 34 degrees Celsius when adrenaline given 6 to 10 minutes interval. Right, but in MRChem success, there is written is 30 to 35 degrees Celsius.
This is taken from ALS. What is given there is not very accurate. I know that it is given 35 degrees in MRChem success. This is taken from ALS. Follow this one.
Okay, then I should follow this one, okay?
Yes. Because strictly they will follow the ALS and RESUS, which are for the UK. Everywhere in the UK, they follow the ALS. So we need to strictly follow the ALS.
Okay, thank you.
So the patient is in stage 1 conscious, so that time we don't need to give shock, right?
I didn't get you. Can you please repeat? Your voice is a little bit muffled.
Patient is stage 1, patient is conscious, like core temperature.
What we expect and what interventions to be done, we'll study in environmental emergencies. We are just put up here. That's why, because that usually less than 24 degrees Celsius, the patient goes in cardiac arrest. To stress that, I have put the classification. Once again, we'll go through this classification in environmental emergencies.
Sir, in the obstetric in patients in obstetric arrest, sir, that 5 minutes we are delivering the patient. At that time, also the CPR has to be continued until the baby is delivered,
Yes.
sir.
Yes, CPR shouldn't stop for any reason. Ongoing CPR, you need to deliver the baby. C-section should be done with ongoing CPR. So you need to be really expert to deliver during ongoing CPR.
Sir, just asking about the shock of defibrillator. It's total 5 shock or just?
For which condition? You usually give one shock in a shockable rhythm. Then you wait for 2 minutes. So the cycle will go on for 2 minutes. The CPR will go on for 2 minutes. After 2 minutes, if it's again in shockable rhythm, you continue giving the shock. So every 2 minutes you check it's in shockable rhythm, you continue giving the shock.
Okay, yeah, just talking about the duration or the time of shock, like until the CPR complete 20 minutes like that? Continuous shock?
You continue giving the shock unless you've corrected all the reversible causes and it's been more than 20 minutes, then you can think of stopping the CPR.
Okay.
Usually what we say is if it's an elderly people and more than 20 minutes and all the reversible causes has been addressed, you can stop it. In younger patients, we usually continue the CPR if the patient remains in VFVT. Usually this recommendation is to continue CPR in younger patients. Usually they'll come up. We have witnessed, I myself have witnessed, we are given 12 shocks and the patient after a few days walked out from the ICU. So younger patients, you can resuscitate if they are in VFVT.
Okay, thank you.
Okay, sir. In case of hypothermia after 30 minutes, when to decide to stop CPR after 30 minutes?
After, we don't call a patient dead till you warm it. So if you warm the patient for 34 degrees Celsius, still there is no ROSC and it has been a long time duration of CPR, then you can think of stopping.
For how many?
It depends on how much time you're taken to warm the patient. Usually we continue CPR for 40 minutes in a hypothermia patient, at least for 40 minutes. Hypothermic cardiac arrest.
Dr. Amin, after 5 shock and give amiodarone, the patient still is VT and VF. What you do?
You continue giving shocks. Only 2 doses of amiodarone is given. We don't give more than 2 doses of amiodarone. One after 3rd shock, one after 5th shock. That's it. We don't give more doses of amiodarone. Only 2 doses of amiodarone is given. Adrenaline will be continued every 3 to 5 minutes. Repeat doses will be given. And you'll be giving the shocks.
Only shock?
Yes. Coming to the post-cardiac arrest algorithm, we are looking, once you got an ROSC, so you've done a good job, you got an ROSC, what you do, you just leave the patient and walk away. You need to reassess the patient from airway, breathing, circulation, deformities you need to look out for. First thing is airway and breathing, which goes hand in hand. If advanced airway is not present, place an advanced airway. Confirm if advanced airway is already present, confirm it with capnography, or place an advanced airway and confirm it with capnography. So ventilate, then you'll be ventilating accordingly. What about circulation? Once enter into the circulation, the first thing you'll be looking for is the blood pressure. Aim for blood pressure more than 100. Systolic blood pressure more than 100. If it is not more than 100 and if you think the patient is hypovolemia was the cause, then you can restore the volume, intravascular volume, by giving IV fluids or the blood. If you think this patient is already been resuscitated enough, the intravascular volume is sufficient, then you can directly start on inotropes or vasopressors to maintain the blood pressure around 100. Systolic blood pressure of 100. Also, you need to get is 12 lead ECG, which is very important. We'll try to maintain the core temperature between 32 to 36 degrees Celsius. Basically, if the patient is shivering, we'll sedate them. Other than that, invasive methods will not be used to bring down the core temperature to this level. That is nothing but therapeutic hypothermia is not done in the ED itself. It's difficult to do it in the ED itself. You have the ECG here. By this time, you should be able to collect the history also. If any one of this is suggestive of an cardiac cause, shift this patient to coronary angiography and angioplasty and shift this patient to ICU. If you think it is not an cardiac cause, if it is in PE, then get an CTPA done. If you think some other cause, consider getting an CT brain. If it might be an intravascular, it might be an intracranial hemorrhage which has caused the cardiac arrest, you might have to get an CT brain, get an CTPA done. If no CTPA done, treat the reversible causes or treat the causes if possible, then admit into ICU. So basically, from emergency point of view, what you're doing, get an advanced airway done and confirm it with waveform capnography. Make sure the systolic blood pressure is more than 100. If required, give IV fluids or inotropes. Get an 12-lead ECG. Depending on the 12-lead ECG, either this patient will go to cath lab or go to CT room to get NCT scans. Then he'll be going to the ICU. In CT scan, if there is something which can be done immediately, for example, there is an intracranial hemorrhage which requires a decompression, then you might have to shift this patient to operation theater. After operation theater, it will directly go to an ICU. What happens in ICU, we are least bothered. We are not intensivists, so we don't care about what happens in ICU. This is not required from exam point of view. That is post-cardiac arrest. Now we are getting into tachyarrhythmias and bradyarrhythmias. Okay. Tachyarrhythmias in bradyarrhythmias, if you go through an ALS algorithm, they keep mentioning about life-threatening features. There are 4 life-threatening features which are same for tachyarrhythmia and bradyarrhythmias, which is shock, syncope, severe heart failure. Remember, it is severe heart failure. It's not in mild or moderate heart failure. It's in severe heart failure or myocardial infarction. They will not mention in the stem of the question the patient is in shock directly. How they will mention or how to pick it up. Shock means for you from the scenario, if the systolic blood pressure is less than 90, the patient is in shock. What about syncope? Sometimes they might say that this patient had a syncope, or sometimes this might be mentioned as a collapse. Sometimes they might mention it as a transient loss of consciousness. Or if any one of this is mentioned, syncope, collapse, transient loss of consciousness, it is a life-threatening feature. What about severe heart failure? Severe heart failure, for all practical purpose for us, is pulmonary edema. That is, on auscultation, he is having bilateral basal clefts. That means he is having a pulmonary edema. Or it might be severe heart failure because of right ventricular failure, where we see an raised JVP. But raised JVP will be difficult to see in a resus case. But if the patient is cooperative enough, you can visualize, tilt him up to 45 degrees, place his laterally rotate to one side and look for raised JVP. But pulmonary edema is the one where they will be testing you out for. Look out in the stem of the question, low SpO2, high respiratory rates. These are the 2 things what you need to look out for in the stem of the question. To label them, they might be in an heart failure, severe heart failure. Myocardial infarction is the history what you're looking out for. If they complain of chest pain, or if you're already taken an ECG which shows an ST segment elevation, a typical chest pain, always think of myocardial ischemia. These are the 4 things what you need to look out for in the history to say there is a life-threatening future. Because if there is a life-threatening future, the management changes drastically for both bradycardia and tachyarrhythmia. So you need to always look out for these life-threatening features in the stem of the question. Coming to adult tachycardia. So we are discussing about adult tachycardia now. First approach is, immediately you're not going and shocking this patient. First approach is you're going through airway, breathing, then coming into the circulation, then you're looking for the tachycardia. First thing what you need to address is airway and breathing. For example, this patient is having low SpO2. Then you'll start him on oxygen first. Not shocking, start him on oxygen first. So those things, airway and breathing, needs to be looked out for first. Then you will be coming to the circulation. In circulation, you are getting a 12-lead ECG. You are connected to a monitor, cardiac monitor. Once you have done all those things, you will be looking for, is there any life-threatening future present? This one is the same thing what we have discussed here. If any one of this following is present, if not more than one, you shock the patient. Remember that here we are talking about tachyarrhythmia. So pulse is present. And don't just shock this patient. You need to sedate this patient. Sedation is important. We call it as a conscious sedation. Sedation is always important before you shock the patient. It is a painful procedure. Patient will slap you if you don't shock, if you don't sedate him and shock him. And you might be sued also if you don't sedate him and shock him. No matter what is the situation, you have to sedate the patient before you shock him. Okay, you will be giving one first shock you are given. If it failed, you can continue giving up to 3 shocks before you consider giving amiodarone. You are given first shock, nothing has happened. Second shock, nothing has happened. Third shock, nothing has happened. Then before giving fourth shock, before giving a fourth shock, you will give an amiodarone. The dose is here. You will be giving 300 mg IV over 10 to 20 minutes. Okay. After fourth shock, still the patient is in tachyarrhythmia and the sinus rhythm is not coming up, still in tachyarrhythmia itself. What you do, you can start them on amiodarone infusion. After fourth shock, you can start again on amiodarone infusion. We are starting here. You're not giving any bolus, infusion. This is the dose of infusion what you are starting. Here we are giving amiodarone bolus 300 mg after third shock. Before all this, you need to sedate the patient. Don't forget to sedate the patient. Okay, sedation is very important. Don't forget to sedate the patient. One more thing you need to remember is the defibrillator should always be in sync mode. If it is not in sync mode, you might trigger an VF or VT, and this patient can go in asystole and into cardiac arrest. So you don't want to cause more harm. So don't forget synchronized. There will be different options given. One option with synchronized, one option they'll not mention about synchronized. So choose the option which are synchronized. Be careful while choosing the options. Don't choose it in hurry. Read carefully. Usually people do mistake by not choosing synchronized. Okay, this is for where there is life-threatening features. If there is no life-threatening features, the next step is you get a proper 12-lead ECG and check for QRS complex. Is the QRS complex narrow or broad? That means, is it less than 3 small boxes or not? If it is less than 3 small boxes, we call it as a narrow QRS complex. If it is more than 3 small boxes, we call it as a broad QRS complex. After we know it is a broad or narrow, we are looking at whether it is regular or irregular. In both scenarios, regular or irregular. First, we'll be seeing narrow. Narrow and irregular, probably it is an AF. We know the treatment of AF. So basically, if the symptoms are more than 48 hours, we'll be treating with beta blockers. If it is less than 48 hours, we are trying to rate control it. We are giving the drugs accordingly. Digoxin is usually preferred in heart failure patients more than 48 hours. Less than 48 hours, amiodarone is preferred one. Anticoagulants, if they are not on anticoagulants, everyone gets heparin. This we have already discussed in cardiology chapter. Coming to regular, if it is in regular, we're thinking about SVT here. So we are going through an SVT treatment. First one is vagal maneuvers. There are various vagal maneuvers which you can do. You can ask the patient to blow through a syringe. You can just do a carotid massage. You can apply some pressure over the closed eyelids. So there are various vagal maneuvers, or you can just ask the patient to close his nose and mouth and try to blow the air and increase the intrathoracic pressure. The various vagal maneuvers you can perform and see whether this will help to revert the SVT or not. If it fails, the first thing you're doing is adenosine you are giving. For giving an adenosine, usually we want a large bore cannula in your cubital fossa. That is in your elbow, cubital fossa in elbow. We need a large bore cannula, a 3-way cannula. Because adenosine is very short acting, it acts for only few seconds. So as soon as you push the adenosine, you will push 20 ml of fluids so that it reaches the heart as soon as possible and it takes its effort. First, we try it with 6 mg. If it is unsuccessful, 12 mg. If that is unsuccessful, this is the new thing what they have added a couple of years back. That is 18 mg you will be giving. Well, all this, obviously, this patient should be in resus and on cardiac monitor. If this is not effective, that means this is not an SVT at all. It might be an atrial flutter, what we are talking about. It might be an atrial flutter this patient is having. It's not an SVT this patient is having. That's when we try with verapamil or beta blocker. If this also fails, then you can shock the patient. Okay, before shocking, it should be a synchronized shock and conscious sedation needs to be given. Now we are coming to a broad QRS complex. Again, we are looking for whether it is regular or irregular. Regular, think about VT. Unless there is a documentation of bundle branch block or aberrant conduction, don't think it is an SVT with an aberrant block. Always think it is an VT itself. Okay. What ALS recommends is amiodarone. But recently, Jan of this month, RCM Learning, if you go across, and many studies, including in ACLS, that is US followed, they say amiodarone is poorly effective in a stable VT. Either you can go directly ahead with an electrical shock, or you can give two drugs, so sotalol or proconamide can be given. Proconamide or sotalol can be given. For why I'm putting this here? In the options, if they are mentioned amiodarone and sotalol, choose sotalol over amiodarone. If sotalol is not present, only amiodarone is present, then go ahead and choose amiodarone. What about irregular? Irregular, we are more thinking it might be an AF plus and bundle branch block. It might be an LBBB or RBBB, what we are thinking. Because if it is an irregular, it might be an AF. This is one of the possibility. The other possibility is it might be an polymorphic VT. Most of the time, whenever it is an irregular, it will be an polymorphic VT like this. It is a polymorphic VT. Polymorphic VT, we are treating with magnesium 2 grams given over 10 minutes. This has again appeared, multiple questions are appeared on this algorithm. Remember this polymorphic VT, if the ECG is give 2 grams of 2 grams of magnesium. If it is an monomorphic VT, we are giving either sotalol or amiodarone, depending on what is there. Sotalol is preferred over amiodarone. Regular, then we are treating as an SVT. If this flops, then only we are thinking about an atrial flutter here. Irregular, it is nothing but AF, treated as AF, what you are learned in cardiology chapter. Anyone has any doubts still here can ask me before we go into bradycardias.
Okay, I mean, between the synchronized DC shock, what should be the time interval? If we give 5 shocks, then how we should wait for a few minutes?
Once you give the shock, it should revert back into the sinus rhythm immediately. If it doesn't revert back, you can give back to back. When you are talking here shocks, we are giving this, you are already given conscious sedation. So first shock is given. You look at the monitor and see whether it has reverted, not reverted, second shock, not reverted, third shock. Then you'll wait to give the amiodarone because it is given over 10 to 20 minutes. Then deliver the fourth shock. Still not reverted. Then start on amiodarone infusion. Then only give the fifth shock.
How long should we wait for giving the second shock within the 5 seconds?
Till you analyze the rhythm. If the rhythm remains in the same, it has not gone back to the sinus rhythm, then you give next shock. Okay, just we are waiting for a few seconds to just analyze the rhythm. We can give back-to-back shocks.
So the energy remains the same, or is it an increment dose you have to do the energy, sir?
Good question. Recommendation is to increase the energies. These are the initial energies what are recommended. Usually it is recommended to increase the energy after each shock. For example, for a broad complex, you have started on 120. Next one you can increase to 140. Next one you can increase to 160. Usually monophasic defibrillators are gone. It is a biphasic, so 200 joules will be the maximum. So you can keep on increasing. Recommendation is to keep on increasing the energy. That's a good question which I missed here. Keep on increasing the energies. So we'll go to bradyarrhythmias now. Bradyarrhythmias, again, we are going through an ABCD approach. So we are, if oxygen is required, we are connecting oxygen. If IV cannula is required, we are connecting IV cannula, getting into a lead ECG done. This is an important thing which most of them forget. What this means here, Identify and treat the reversible cause. For example, if this patient is, for example, beta blocker overdose, here, then you will give it here itself glucagon. So the reversible agent glucagon is given here itself. Okay, we are not even going to then evidence of life-threatening signs to look out for. Treat the reversible causes. For example, this bradycardia, it might be because of hypokalemia. Treat the hypokalemia. Give him potassium immediately here. We're not thinking of atropine or anything. So the treatment here, according to the ALS algorithm itself, identify and treat it here itself before you go ahead to the next step. Next step is looking for evidence of life-threatening signs. This remains the same, that of the tachycardia, no changes. Shock, syncope, myocardial ischemia, severe heart failure remains the same, no changes here. If life-threatening features are there, bradycardia is enough. We are still not analyzed the rhythm. Any bradycardia with an life-threatening feature gets an atropine, first dose of atropine, that is 500 max IV. They get it immediately. If then if you have a satisfactory response, then you'll go for risk of asystole. You'll be looking for risk for asystole. If there are no life-threatening features, then you're directly looking for risk for asystole. This is important. You need to remember this. They will ask you questions on this. Is there a recent history of cardiac arrest which is suggestive of an asystole? Or the ECG, what you're seeing is a Morbis type 2 block, or there is a complete heart block with a broad QRS complex, or there is a ventricular pause for more than 3 seconds. If any one of this following is present in the ECG, then you need to go for this block. If there are none of this following, then you just observe the patient. So you're given first dose of atropine, the response is non-satisfactory, or one of the risk factors of asystole are present, then we are going into this block. This block is very important, and confusion usually happens in this block. We have options here what to do. You can give further doses of atropine for a maximum of 3 mg. So you can give second, third, so you can give 6 doses totally of atropine. Or you can start second line of drugs as mentioned here, like isoprene, adrenaline, or alternate drugs like here what is mentioned. You can give those drugs. Or you can place them on transcutaneous pacing can be placed. Okay, how to choose one over the above if all are there in the options? You need to see what is the cause. If there is a cause given in stem of the question, then we'll be choosing one above the other. For example, here, if this patient is on regular beta blocker dose, then we'll start an adrenaline infusion directly. If this patient is in cardiac transplant, then there is a contraindication. This will come back. If there is a cause because of spinal injury, then we'll start an aminophilins. Okay, those things you need to look out from stem of the questions to choose second line of drugs. If there is no obvious cause from stem of the question, what does ALS prefer? ALS prefers transcutaneous pacing over second line of drugs. They say if atropine you are given and they usually it's not reverting back, or the bradycardia is, the heart rate is not increasing, then they recommend instead of going for second line of drugs, go first for transcutaneous pacing. This is from the ALS book I'm talking about. If you read the ALS book, they say choose transcutaneous pacing over second line of drugs unless there is an classical indications which we'll be going through later on. Okay, that is very important. If all this fails, then you need to seek experts' help for transvenous pacing. If any one of this also is helpful, also you are seeking for experts' help because cardiologist is required. This patient will require and transvenous pacing eventually. One more thing is whenever there is a transcutaneous pacing, this patient requires sedation. Now let's talk more. Coming to, I have mentioned here doses. Other than atropine dose, you did not remember any other doses. Any other doses are not required from exam point of view. They'll not test it. Okay, this is assumed. These doses, no one remembers it. It's difficult to remember it. There will be protocols in place. We'll follow the protocol. Adrenaline infusion, there will be a protocol in place. The nurse will know to follow the, you'll just tell the nurse to follow the protocol, start an adrenaline infusion. Now we are talking about transcutaneous pacing. So transcutaneous pacing, First, we'll be placing the pads. This is similar. There is no changes. One is below the right clavicle. Another one is in this position, what is shown in the picture. Then the defibrillator, you need to choose for the pacer mode. Once we have choose for the pacer mode, two options will appear. One is to select the joules, that is energy, milliampules. Another one is to select the heart rate. Usually we'll select the heart rate around 70 beats per minute. 70 is the thing what we select usually. We don't select more than 70, we select 70. Okay. You can select anywhere between 60 to 90, but 70 is, everyone is happy what you have seen. So you will select 70 beats per minute. Once you are selected, there is an electrical activity which will be captured on the monitor as well as on the ECG generated from the defibrillator. This electrical activity is nothing but straight line what you have drawn here. We want after every straight line, there should be an QRS complex. Here you can see there is an absent QRS complex, absent QRS complex. Here it is present. There is an absent. That means there is no electrical capture. After every straight line, that is the electrical activity generated by the defibrillator, if there is an QRS complex after every straight line, that means the electrical capture is present. Okay, electrical capture is satisfactory. Once the electrical capture is satisfactory, then we'll be checking for the pulse. Okay, if pulse is also present, that means you have you have successfully paced this patient. Okay, remember that you need to always check for the pulse. And for example, sometimes the pulse might be 30 beats per minute. You're counting the pulse here. 30 is not satisfactory. It should be 70 because you're pacing at the 70. Sometimes what happens is you selected a certain joule. For usually we started from around 30 milliampules and we keep on increasing it. When do we increase this? First, you have placed on 30 and you see this one, there is no electrical capture. So you'll keep on increasing till you get an electrical capture. The maximum you can increase is 200 milliampules. Once you increase 200 milliampules, till the patient is not having an electrical capture, that's when you can change the pads. What do I mean by change the pads? Usually we keep it the pad position in this way. Now we are changing to anterior posterior position. So one we are placing right in middle, another one you are placing exactly opposite to it. So back of the patient you are placing. So change the pad positions if it is not getting captured. So those are the steps what you need to look out for. You know to look out first, select the energy, select the heartbeat, look out for electrical capture. If you're not getting, keep on increasing the joules. If still you're not getting, you reach the maximum, change the pads. Pads, you must be getting it. There is no way you can tell you'll not get it now. Once you get it, electrical activity is there, so electrical capture is there. Then you will be looking for the pulse. Pulse, what we call it as a mechanical capture. Pulse should be 70 beats per minute because you have selected 70 here. If it is 70, then mechanical capture is also there. For example, you increased till 100 millimoles, you have got an electrical capture. Pulse you are checking, it is only 40. You have selected 70, but it is 40. Then again, you are increasing the energy till you get a mechanical capture. That means till you get a pulse of 70 beats per minute. That finishes transcutaneous pacing. More we need to know about the when to choose which drug in an bradycardia. We are again talking about this part here. Okay, first look out for the cause. If it is an inferior wall MI or a spinal cord injury, then first dose is always atropine here. That is 500 max atropine, followed by aminophylline infusion you'll be starting. In cardiac transplant patient, don't use atropine at all. Atropine is contraindicated because this is a cardiac transplanted patient. Okay, there is no how does atropine act? Atropine acts on vagus nerve. Okay, vagus nerve will be disconnected because this is an other heart, so all the nerves will be disconnected. So don't use atropine. Atropine will directly act on the conduction system and will cause high degree blocks, and this patient will go into cardiac arrest. So in cardiac transplant patients, just use aminophylline is the preferred drug. What about if the patient is on regular doses of beta blockers? If the patient is on regular dose of beta blockers, usually atropine doesn't act well. Okay, so first dose of atropine you'll give. After that, adrenaline acts better, so you'll start an adrenaline infusion. What about the bradycardia is because of beta blocker or calcium channel blocker? Here in your notes, it is mentioned as atropine first followed by glucagon. Please correct it. It's glucagon what we'll be giving first. Why we are giving glucagon first is if you go through the algorithm, here itself, if they say if there are any reversible causes, treat them, like electrolyte imbalances, like overdoses, for example, calcium channel blocker overdose or beta blocker overdose, give glucagon. Okay, this finishes our brady and tachyarrhythmias. Anyone has any questions can ask me.
Sir, in bradycardia, after giving the 500 microgram IV, in the interim measures, it is mentioned as again atropine 500 microgram IV repeat to maximum of 3 mg. So is it like in that time we can give again 6 times? So total of it will be coming as 3.5, or only 5 times will be repeating it, sir?
5 times you will be repeating. Total should be 3 mg. Only 5 times. Total you will be giving 6 doses. Total is 6 doses. Okay, so you'll be repeating 5 more times here.
Okay, thank you.
Okay, thank you. Dr. Amin, like we were discussing one MCQ, same like one patient received 500 mic atropine, and after that the options were 3 mg bolus, this atropine, it's not possible. The second were isopranoline infusion. And I think so there were no.
I understood what you are
there
asking me.
Mhm.
The question was basic. I think you need to mute it. Yeah, thank you. I understand what you are asking. There was an option of giving atropine 3 mg bolus, and the confusion was between the option of isopranoline. Okay, atropine 3 mg bolus we don't get. What we are giving here is we are giving 500 max. That is 0.5 mg you can give at a time. You can't give a bolus of 3 mg in total, or maximum what you can give is 3 mg itself. Okay, that's the reason we are choosing isopranoline over atropine 3 mg bolus. Isn't wrong dosing what is here. That's the reason we are choosing an isopranoline over atropine. If the dose was given correct, then both the options would have been relevant here. You would have selected each. Both the answers would have been correct basically if dose was given correct. Because the dose was given wrong, you are choosing isopranoline over atropine.
And if there would be option of transcutaneous spacing and isopranoline, we will go for transcutaneous spacing.
Yes, you are right.
Okay.
Transcutaneous spacing is preferred over second line of drugs.
Doctor, if we have patient and the patient unconscious.
Drugs options. If there is delay of transcutaneous or not available spacing,
then you can give second line of drugs. If there is a delay in transcutaneous spacing, you can give second line of drugs.
Doctor, if there is patient with bradycardia and the patient unconscious and you don't know the history, you don't know if the patient have you should start aminophylline or glucagon overdose or anything. What we will start for the patient?
First, you will be giving, if the pulse is present or not, you need to first check because the patient is unresponsive here. If the patient is without pulse, then is in pulseless electrical activity, you will be treating according to the cardiac arrest algorithm. If pulse is present, then we'll be going according to this algorithm. Atropine you'll be giving, repeat up to 6 doses of atropine. It is not working, then I'll go ahead with transcutaneous spacing because we don't have any history at all.
Dr. Amin, I
Yes.
just want to ask about this. You said in bradycardia with adverse feature, so first line atropine and the second line to be cardiac patient. Even I know the patient have like digoxin toxicity. Can I use the digoxin specific antibiotic before the cardiac patient or the cardiac patient first?
That is a reversible cause. Okay, digibind you can use if there is a digoxin which has caused an bradycardia in this patient. You're treating here itself. Digibind is given here itself. Okay, before an atropine itself, we can give digibind.
Sir, if the patient is hyperkalemia, in the hyperkalemia, it also give also bradycardia. So how we treat in this case?
Treat the hyperkalemia first. Again, electrolyte abnormalities, you'll be treating here itself. Treat the hyperkalemia first. You have treated the hyperkalemic cause still in bradycardia, then give atropine, then you are going according to the algorithm here. This algorithm.
So the
ventricular
reversible
pulse.
agent before the cardiac pacing.
Before the cardiac pacing itself, you will be giving the, if there are reversible
Reversible
causes,
stage.
you need to change, treat those reversible causes.
Okay.
So in bradycardia algorithm, we start with the atropine 0.5 milligram. Is it necessary that we finish the doses of atropine till 3 milligram, you go to the second line of drug, or in between you can choose isoprenaline?
You can choose in between isoprenaline, especially in special circumstances like this. You know the cause. This is an inferior wall MI which is causing. Go ahead with aminophylline. And patient is on beta blocker doses. No point in giving more doses of atropine. Go ahead with adrenaline infusion. It is a beta blocker toxicity. If you've forgotten to give glucagon, give glucagon.
So can you just explain me this ventricular pulse more than 3 seconds in case of bradycardia algorithm?
It's an ECG what you're looking for. Okay, in this ECG rhythm strip, you need to look out for ECG. So there is one QRS complex here. There might be a P waves here in between or no P waves. The next QRS complex is appearing after 3 seconds. The duration from here to here is 3 seconds. That is called as ventricular pause for 3 seconds.
Okay, sir. Thank you.
So we are going into pediatric basic life support. It's pretty much similar to that of adult basic life support. So first you are checking for unresponsiveness. The kid is not responding here. Then suddenly you will call for help. 4 twos, 22 and 22 is the resuscitation call number which is used widely in NHS. Okay. Still, once you call for the help, then you will be opening the airway. What do I mean by open the airway? Open the airway means either in a traumatic case you're doing a jaw thrust maneuver, or in head tilt maneuver what you're doing in an medical cause. It's not in traumatic, it is a medical cause what is there. So you're doing a head tilt. Then you are looking for sign of breathing. That is important. You're tilting the head and looking for sign of breathing. Because if there is a tongue fall, it will open up the tongue fall. If you see here, they have mentioned breathing. They're not mentioned signs of life. They are mentioned. They're not specifically mentioned the carotid pulse. Or in pediatric, usually we don't check carotid pulse because the large size of the head, usually brachial artery, what we are checking for. Okay, that is inside of your arm against the humerus. You will be pressing in the mid position for checking for the brachial artery, what is preferred one. Most of the time in pediatric cases, it is the hypoxia which is causing arrest. Please mute. Most of the time, it is the hypoxia or the respiratory cause which is causing the cardiac arrest rather than the cardiac cause. So pulse doesn't take importance here. It's the respiratory efforts what you are seeing. If there are no normal respiration, for example, the patient is gasping or he is having seesaw respiration, or if you're in any doubt, that's when you give him fire rescue breaths. Once you give him fire rescue breaths, still the patient is not having a proper respiration or there is no respiratory efforts at all, then you will start chest compression in the ratio of 15:2. For every 15 chest compression, you give 2 rescue breaths. This is mainly because we give so more frequently compared to the adults, because in pediatric, it is most, if not always, the respiratory cause for the cardiac arrest. Then we are entering into the pediatric advanced life support. Before we enter into the pediatric advanced life support, you need to remember these things. Okay, what we know as wet flag. You get a call from an paramedics on red phone saying we have a 3 years old child in cardiac arrest, ongoing CPR, estimated time of arrival of 5 minutes. So you have 5 minutes. In 5 minutes, what you do is on a whiteboard, calculate wet flags. Wet flags is a mnemonic which stands for weight, electricity, tube, fluids, lorazepam dose, adrenaline, and glucose dose. So if the patient is less than 1 year of age, you use this formula to calculate the weight. 1 to 5 years is this formula. 6 to 12 years you're using. More than 12 years we consider him as adult and can be used as 70 kgs as an adult. Electricity is 4 joules per kg in a cardiac arrest scenario. ET tube size. I'll come back to the ET tube size. Fluids, if it is a medical cause or traumatic cause, it's 10 ml per kg. These are the new guidelines. It's 10 ml per kg. Don't get confused. Lorazepam dose is 0.1 mg per kg. You need to remember. Adrenaline dose is 0.1 ml per kg of 1:10,000 dilution when you are giving it intravenously. If you're planning to, if you're not able to secure it an IV line, and when you are not able to secure an IO line also, then you can give it through an ET tube if ET tube is in situ. The dose here is 100 mics per kg, 1:1000 dilution. Remember here we are using a concentrated solution here, 1:1000 dilution. The ET dose of adult is double. You need to double it in an adult, which I forgot to mention. You need to double it ET dose in an adult. Glucose, what you're giving is 2 ml per kg, 10% of dextrose. You can give up to 5 ml per kg also. Initially, we'll be giving 2 ml per kg. This is in hypoglycemia. We will give 2 ml per kg of 10% dextrose. We can give up to 5 ml per kg. This you need to remember. This is important from exam point of view. In I think in the last April diet, if not in April, October diet, ET tube size has been asked. 2 questions had appeared here. Remember that curved ET tubes are the preferred ones. If you see in OHEM or if you see in Tintinelli, they prefer or they suggest that use curved tube no matter what is the age, unless there is an preterm baby. If there is a preterm baby, then you can use an uncuffed tube. 3.5 size is the standard size. Cuffed tube less than 1 year is 4 what you're using. More than 1 year of age, this is the formula what you need to use. This is the internal diameter what they will be keen on. Length is not required to remember for exam. This is the cuffed tube internal diameter formula. You need to remember, you need to calculate. If in the stem of the question, if they mention cuffed, it is easy, you're using that formula. If they mention what is the size for this age for an uncuffed tube, if they mention only, then use this formula, that is age divided by 4 plus 3.5. If they are not mentioned as uncuffed tube, assume that they are asking about cuffed tube and use this formula only to calculate. So this is important. They will ask you questions on the wet flag. Now getting into the pediatric cardiac arrest scenario, it's very much similar to that of an adult. There are nothing much changes, only minute changes are there where I'll be stressing on. CPR is done at ratio of 15:2. Don't forget that one. Once defibrillator is connected or the monitor is connected, you'll assess the rhythm to see whether it is a shockable rhythm or non-shockable rhythm. If shockable rhythm, you will shock and continue CPR, no changes. Non-shockable rhythm, that is nothing but PE and asystole, again no changes here. Only the dosing changes. This is the adrenaline dose what you need to remember. And the dose for the shock changes here, that is 4 joules per kg. In cardiac arrest scenario, it is 4 joules per kg. So remember, don't forget that. This, and there are 4 H's and 4 T's, quite similar to that of the adult cardiac arrest. Most of the time it is hypoxia in pediatrics. Pediatric cardiac arrest is hypoxia unless and until proven otherwise, unless it is a traumatic case where they are thinking about hypovolemia. Otherwise, always we think about hypoxia in pediatric age group. And pediatric cardiac arrests are quite rare, and the questions which appear in the exam are less. Coming to Tachy and Brady arrhythmias, this slight change in Tachy and Brady arrhythmias treatment, what we do in pediatric compared to that of the adults. Okay, usually cardiac causes are rare, so this is also rare to appear in the exam. But you need to remember there are few questions which have appeared in free diet in the previous diet, so you need to remember this. So approach is similar. ABCD approach is similar. Signs of circulation if not present, then you go to advanced life support algorithm, which we have already seen. Then we'll be thinking here, we don't call it in pediatric as life-threatening features. We call it as an either decompensated or compensated. If it an decompensated, how we know decompensated? That is a loss, there is a loss of consciousness or reduced GCS, or there is blood pressure is less than 5th percentile, capillary refilling time is more than 3 seconds, or weak impalpable peripheral pulses are there. All this suggests of decompensated. What we do in a decompensated kid who has a bradycardia, okay? Bradycardia, we call it in less than 1 year if it's less than 80, in more than 1 year, less than 60. Okay, you need to remember this one also. we straight away don't jump and give atropine in this scenarios. We know in pediatric cases, it is hypoxia, which I call most of the time it is hypoxia, which causes bradycardia. So we end up giving an atropine. We end up giving just an oxygen initially. If oxygen, there is no response, that's when we tend to we tend to see the cause. If you see it is a vagal stimulation which has caused the bradycardia, that's when you give atropine. If there is no response to the oxygen and atropine, that's when you can think about adrenaline. Most, if not 100% of the time, 90% of the time, at least oxygen will be helpful. That's why they're stressing on oxygen here. Drugs will usually not be using in pediatric age group. What about tachycardias? Remember that in infants up to 120, up to 220, it can be sinus tachycardia. In children up to 180, it can be sinus tachycardia. So closely have a look at the heart rate in the ECG, what they are given, or in the stem of the question, what heart rate they are given. Closely have a look. It becomes difficult when the heart rate is around 200 to differentiate between sinus tachycardia and SVT, because the heart rate is so high, you may not be able to visualize the P wave at all. P wave will overimpose the QRS complex. So only the heart rate will be helpful to differentiate between a sinus tachycardia and SVT. So in an infant, if it is more than 220 and P wave is absent. In a child, if it is more than 120 and 180 and P wave is absent, then only consider it as an supraventricular tachycardia, or else it is just an sinus tachycardia. Treat the underlying cause. Coming to supraventricular tachycardia, it is a decompensated one. We usually tend to give an synchronized cardioversion if it is immediately available. If there is any delay, then what we can do is we can give adenosine as the first line of drug. Okay, adenosine can be given as in first line of drug if synchronized cardioversion is getting delayed, because synchronized cardioversion requires unconscious sedation. If that is getting delayed, you're not getting the anesthetic, you don't have one more doctor available, then you can consider giving adenosine first. Okay. Shocks, just remember shock, amiodarone you need to give after third shock. We usually don't go to that certain extent. VT, we shock the patient. If they're conscious, we shock them, synchronized shock. If they're unconscious, what we do is we can avoid the conscious sedation and directly go ahead and shock this patient if they're unconscious. Because if they're unconscious, that means they're already been sedated. So no point of sedating this patient because they're already unconscious. What if they are compensated already? Okay, that means none of these decompensated signs are present. That is, CRP is elevated, weak pulses are there, or BP is less than 5th percentile. All those things are not there. Then we just treat the cause. Most of the time, it will be an SVT if they are completely stable. So vagal maneuvers will be fine. If that is if that is not effective, then you can use adenosine. So this is about tachy and bradyarrhythmias in pediatric age group. There is an extensive dosing depending on the kgs and weight and all, which is, for me, if you ask me, it is difficult to remember. If you can remember, it is well and good. You need to remember all this, which is taken from the pediatric life support. At least if you're struggling to remember, because there are many dosing what is here, at least remember this. This is the minimum what is required from exam point of view. They're not tested anything beyond this from exam point of view. Remember, this much should be sufficient from exam point of view. Adrenaline dose, it is 10 mics per kg. You need to remember. Amiodarone is 5 mg per kg. Synchronized shock dose. First synchronized shock dose is 1 joules per kg. If it doesn't revert back, you usually increase it to 2 joules per kg. You double it. Maximum you can reach up to 4 joules per kg. This is the same dose what we give in cardiac arrest also. Systolic blood pressure, 5th percentile, what you can do is 70 plus age into twice. It will give grossly, it will come to similar to this one. Okay, grossly it will be similar to this one. So you can use this formula if you're not able to remember this. Ideally, you remember this, you can answer faster the question, or you can remember this. Why I am stressing on 5th percentile here? If it is less than 5th percentile, then only we call it as an hypotension in pediatric age group. It's not less than 90, it's less than 5th percentile. For that, you need to remember this formula or this one. Grossly, both will come to normal. They will not be equal, but they will come grossly to normal. But remembering this will be more helpful. So remember these two algorithms, at least for the exam, it is very helpful. Anyone has any questions regarding pediatric resuscitation, what we have discussed so far, from cardiac arrest to bradytachyarrhythmias, can ask me now.
Sir, uncuffed tube size in case of kids.
It's h divided by 4 plus 3.5.
Okay.
H divided by 4 plus 3.5. Okay, with cuffed one, it becomes, instead of 3.5, it becomes 4.
So
Okay.
In newborn, there's a difference.
Newborn is different. Resuscitation we'll be discussing later. Okay, in coming up slides, we'll be discussing today. By the end of the class, we should be able to finish the newborn. So it is different. Okay, newborn is completely different. We'll be discussing now. In just few slides, we'll be discussing. Coming to pediatric foreign body airway obstruction, or adult also will be discussing. So foreign body obstruction in the airway we're talking about. So it can be in trachea, or it can be in bronchioles, bronchi and bronchioles. Mainly we're talking about trachea here, that usually causes life-threatening features. So whenever you're suspecting in foreign body in airway, always call for the help and check for the cough, whether it is effective or not. Two things we are checking in the cough, whether it is effective or not, also means if they are mentioning weak cry, unable to talk, or unable to talk in a single sentence, that means this patient is having an ineffective cough. This both things means the same thing. The cough is not effective. If the cough is not effective, we are seeing few things. If the cough is effective, you just encourage the kid to keep coughing. Will not be doing anything else. If cough is ineffective, then we are checking if the child is conscious or not. If the child is unconscious, that should be sufficient enough for you to give him 5 rescue breaths and start the pediatric basic life support, what we had discussed. If the patient is conscious, then you need to see whether it's an infant or child. First, we'll be discussing about infant. For infant, what we'll be giving is, we'll be giving 5 back blows as shown in this picture. Okay. After 5 back flows, you will check whether the foreign body can be visualized in the mouth. If not visualized, or the patient foreign body has not been thrown out, then we'll be turning around and giving 5 chest thrusts. 5 chest thrusts are different from giving an CPR, what we do. The position is same. We usually use 2 fingers. That should be sufficient, or you can encircle the chest and give it by the thumb. So the position and the technique is same, but here you're going much more deeper and much more faster, so that the intrathoracic pressure increases and the foreign body gets expelled outwards. What if it's a child? If it's a child, you're giving 5 back blows. Like this, 5 back blows. You're kneeling down, giving a 5 back blows. If the foreign body is not expelled out, or it is not in the oral cavity, then you're giving abdominal thrust like this. You're kneeling down. Sometimes you might have to use just one hand because the kid is small, energy required will be less. Just you are placing it just below the xiphisternum, and you need to give this abdominal thrust backwards and upwards. So in this direction, you need to be giving the abdominal thrust, and the hand position, what is shown in this picture. What about in adults? Adults also, it is kind of similar. Okay. So what we are looking for is the cough is effective or not. If the cough is effective, just encourage him to keep coughing. Usually they'll expel it out. If cough is not effective, then you need to check whether the patient is unconscious or conscious. If unconscious, start the CPR. If conscious, you're giving 5 back blows. Then you look whether the foreign body is expelled or not. If not expelled, then you'll be giving 5 abdominal thrust. It is also known as Heimlich's maneuver. One thing you need to note here is, if the patient is unconscious in an suspected foreign body ingestion, you need not check for the pulse. If pulse is present, also you're starting the CPR. This is only the condition in adult where if the pulse, central pulse is present, for example, carotid pulse is present, but this patient is unconscious, you're starting CPR. This is the exception here. You need to remember this. They have tested previously in the exam, so this is important. So here, what you can do is, if you have a skilled person in the ED department, you can do a laryngoscope, and if you're able to visualize the foreign body, you can remove it using a Megal's forceps. If the patient is becoming unconscious and you started CPR, early intubation is helpful. Why early intubation is helpful? For example, if the foreign body is in trachea, while intubating, just use this tube to push this foreign body in one of the bronchioles, then pull it back and just intubate the other bronchiole, main branch of the bronchiole, main division of the trachea, and just intubate this lung. This might save his lung. That's what is mentioned here. Sometimes after you're doing this one also, you might not be, you don't know you pushed this one foreign body here or not. The ET tube might be in this position itself, or here you're basically, you can't reach till this bifurcation. Sometimes ET tube reaches only here and the foreign body is here. That's when you will be requiring front of neck access. That is nothing but cricothyroidotomy. You need to do it in these scenarios. This is more changes what you are talking. What further you can do other than the algorithm what's mentioned here, other than starting the CPR, is mainly after you started the CPR, what you can do, what we have discussed here. This X-rays commonly appears in the exam. So here what you see here is, this lung is the affected lung. Okay, this is an hyperinflated lung. So foreign body is in this bronchiole, foreign body is here. Why it is an hyperinflated lung, what we are seeing here? Why this is an affected lung here? What happens here is, in the trachea, when the foreign body is here, when you are inspiring, that means the pressure is reduced in the lungs. You suck this foreign body. You suck this foreign body along with the air. So air is trapped here. So first initially air will come, then the foreign body will come. Air is trapped here. So as the air is trapped here, it looks more black in color because air is trapped there. You can't expire it out because this foreign body has obstructed here. That's the reason this lung is the affected lung. So foreign body is seen in which bronchiole? If this is right and left, it is seen in the right. What you need to, or obstructing which lung? It is the right lung what is obstructing. What you need to tell, or what you need to choose in the examination. That is important from exam point of view. Remember this X-ray, the more blackish in color is the affected lung, not the other side. And this is the pathophysiology, why it looked like this. Anyone has questions regarding the foreign body inhalation can ask me now. Okay, we'll go into newborn life support then. Newborn life support is slightly complicated. Usually we are not that much well versed with newborn life support, but you need to be remembering for the exam questions have appeared. This is important. Okay, so first thing is first here. We don't check like in pediatric here, check for the lives of sign. All those things are not there. You need to strictly follow the algorithm what is given here. Soon after the birth, delay the cord clamping if possible. Usually we delay for a minute if possible. If not possible, we'll just clamp it. After that, what we'll be doing is we will dry the baby, wrap him with a warm clothing and stimulate it. Usually we tap the heel and stimulate. Once you have done this, then you will be assessing for 4 things. One is for color, what you are assessing. Check whether the baby is pale or bluish in color. Check for tone, whether there is an increased or the baby is floppy tone. Check for breathing effects. Are there any breathing effects or not? Check for the heart rate. The 4 things what you need to look out for, what is mentioned here. Is any one of this following is abnormal? For example, bluish cyanosed kid, floppy kid, no breathing effects, heart rate less than 60. Heart rate less than 60 here. Okay, then what you do is you you give them breaths. Usually we give 5 inflation breaths. If you are having an CPAP, you will be using an CPAP to give this inflation breaths. During this inflation breaths, you need to look for chest rise. If chest rise is there, that means inflation breaths are adequate and what you're giving is good enough. If chest rises are not there, if chest rise is not there, what we are doing is, if chest is not moving, then check the mask, whether the sealing is proper or not, check that. If sealing is proper, then use 2% technique. One is holding the mask, other one is just back masking. If that is also good, still chest rise is not there, do suctioning. Okay, if required secretions are there, do suctioning. If secretions are not there, place an laryngeal mask or you intubate the patient. Okay, then you keep repeating and looking for chest rise. You should be able to get chest rise with all these techniques. So each one you will be doing and seeing whether there is a chest rise. If you are able to give 5 rescue breaths, then still the patient is in bradycardia. That means heart rate is less than 60. That's when you will start the CPR at the ratio of 3:1. That is 3 compressions to 1 rescue breath. Along with high increased oxygen to 100%, and you'll be giving rescue breath after 3 compressions, 1 rescue breath with 100% oxygen. Okay. After 30 seconds, till if it persists, that's when, after 30 seconds, if it still persists, that's when we secure an IV cannula and think about drugs. Otherwise, drugs are not given. One thing which I missed here while telling you guys here is, if chest is still moving, chest is moving properly, then you can continue giving chest. We can continue giving breaths for 30 seconds. Then we start the CPR. Let me repeat it here. So you're given 5 rescue breaths and these are adequate. That means chest rise is there. Chest rise is present. Okay. Then you're checking heart rate. Heart rate is less than 60. Then what you'll do is you will be giving, you will be basically ventilating the patient for 30 seconds. 30 seconds, that is every 1 second you are giving 1 breath, 1 breath. After 30 seconds, still the heart rate is less than 60. That's when you start CPR at the ratio of 3:1. Okay, you need to remember this algorithm. If while you're giving 5 rescue breaths, if chest rise is not there, remember this interventions. That is, first check for the sealing, whether the mask is fitting in proper or not. Use open airway techniques. Use 2% techniques. This is first, this is second, this is third, this is fourth, this is fifth. You need to go after each intervention. You need to see whether the chest rise is there. If chest rise is there, next intervention is not required. This is the algorithm. What you need to remember. This is very important. They have asked questions and questions can appear. Don't ignore this. Any questions regarding newborn algorithm can ask me, or any questions from anywhere in the class can ask me.
So the newborn, what's that meaning with starting with air in air? Does it mean that without oxygen, or is it the room air we are supposed to deliver the 5 rescue breaths?
5 rescue breaths is given with oxygen itself. It's 100% oxygen what we are planning to give here. Okay, basically what they are telling here is, sorry. Basically what we are telling here is, usually we connect to an CPAP and we give the rescue breaths what you're giving. The circuit is itself different. Okay, it's not a normal bag mask what they recommend. If you're having a normal bag mask, the high flow oxygen what you give here can come up to FiO2 of 80% itself. They're planning to give FiO2 of 100%. Then it becomes difficult. Then we use special masks which are available here. Okay, if we here, your question is, if I'm not wrong, why they have mentioned 100%? Why here itself we can start at 100% itself? They mentioned here is, if at all, if you're not using 100%, use it here. If at all, if you're not using, if it is already 100%, then continue the 100%. You can start using 100% here itself.
Now, what is the meaning of start in air, sir? Is it not the room oxygen? Or?
Sorry, which one? This is the pressure. If you have this equipment, there is a special equipment that is a CPAP for newborns is available. If available, then you will be starting on the room air itself. It's not the 100% oxygen. That's why they say here 100% oxygen. Most of the time, this equipment will not be available in the ED. That's why we end up giving 100% oxygen and doing it.
Doctor, here in CPR in the infant, to do 3 chest compression to
3
ratio
is
of
to 1.
1.
Yes. It's 3 is to 1. In pediatric age group, 15 is to 1. In adult, it is 30 is to 2. 15 is to 2. This is adult. This is pediatric. This is newborn. Anyone has any questions?
Yeah, sir, in case of transcutaneous spacing, the maximum current what we can increase is
200, up to 200 you can go.
okay, sir.
Usually in the scenario, they will mention it as maximum has been reached, because sometimes in some manufacturers, it may not go up to 200. That's the maximum what you can go, but some defibrillators might not allow 200.
Dr. Amin?
Yes, please.
Regarding the resuscitative thoracotomy, there is a limited time for do it your CPR, yani from trauma, time of trauma.
Still you do a thoracotomy itself. That doesn't take much time. You have to just put in big incision and use big clamps and open the chest. Those are the recommendations. It's being followed in UK. It's not that just the recommendation. It's being followed in the UK. Okay, it looks like this once you open it with using the clamps.
Sir, main adult.
Can you please repeat your voice? I couldn't hear you. Okay, anyone else? Any questions? Yes, please. You can ask me.
Hello.
Yes, please.
You thought obstetric cardiac arrest if the patient is
bradycardia after one shot of atropine in adult bradycardia after.
Can you just type it and send the questions what you are having so that we go through the message? Just type it because I can't hear you. Type the question what you are asking here in the chat box so that I can check the chat box. You can just type it in the chat box so that I'll have a look.
I have a question.
Yes, please.
If in case of obstetric cardiac arrest, the patient is more than 20 weeks pregnant, you told me that within 5 minutes CS. But if there is no facility to do the CS, then what we will do?
Those are the ideal situations we are talking about. If still you're not happening, then we'll be going to a lateral tilt and resuscitating if you don't have the facilities.
Okay.
Okay. Because we are thinking about an ideal emergency department, an ideal scenario here. Sometimes you might not have the equipment itself to do an C-section in the ED department. So it will obviously be more than 5 minutes to do it. So as soon as possible, you will be doing it. You will be involving the gynecologist as soon as possible and doing it. If not 5 minutes, ideal situation is to do it within 5 minutes. Yes, please. Someone else had the question. If mic is not working, you can type and ask me here.
In case of infant, you told me that 5 back blows and 5 chest thrust. Up to which years?
Infants we use. You mean by foreign body injection you're asking about, if I'm not wrong?
Yes.
In foreign body injection, infants we are giving chest thrust. In child that is more than 1 year, we are giving abdominal thrust.
More than 1 year. Okay.
1 year. More than 1 year. So basically, 1 year they will be able to stand. That's the age you can go back and really give an abdominal thrust. Someone else had the question? Okay, then we'll stop here. Thank you, everyone.
Thank you, sir.